haranguing the sheriff every week for like 2 months. They found a vulnerability. Pardon?
What was that?
A needle exchange.
Needle exchange. Okay, great.
Needle exchange, yeah. They have a massive OUD problem. There was no needle exchange in the county. And so they went and harassed the sheriff and the city council until it happened, right? They kind of power mapped who had, I don't know if y'all do power map exercises, but they figured out who had power in their community, who had some democratic accountability, and went out and just harangued them until they got the things they needed. They organized around that. In chapters in Texas, a little bigger than yours, but San Antonio is not that much bigger than y'all's is right now, or at least it wasn't a couple of years ago. They won paid sick leave. It was a statewide coalition. It was a ballot proposition. Paid sick leave turned out 144,000 people in San Antonio, which is 3 times more than the number of folks that voted for mayor in the previous election. And that was just all ground canvassing. They had a little bit of funding, but it was mostly a pretty grassroots effort. Folks hitting the street, getting out there and trying to build the thing. An extreme example is Reclaim Idaho. In Idaho, 3 folks brought a Winnebago. So Idaho didn't have Medicaid expansion, which means that rural hospitals close, outcomes are miserable. 50,000 people didn't have insurance and kind of getting ground through the gears. So 3 friends bought a camper van, painted it green, and drove across the entire state trying to get a petition together to put Medicaid expansion on the ballot in the 2018 election. And they drove around and had town halls in every county across the state, and kind of invited whoever wanted to organize, gave them the keys to the kingdom, and put together a petition that succeeded in getting on the ballot, and then organized even harder for the next 4 months to win the thing. And it ended up winning 61% of the vote, which is incredible. It passed overwhelmingly, even though the Dem nominee for governor lost by 22 points. It wasn't the blue wave, it was like a mass popular movement that was started by literally 3 people driving around the state. Now, their time and resources might be different than yours, but they went ahead and analyzed what things are possible, what issues have popular appeal in the places around us, what ability do we have to organize around, in this case, both San Antonio and in Idaho, a ballot drive for a ballot petition. Went ahead and pushed on that. I can't tell y'all what to do, because I don't know what's happening in y'all's part of the country. But I don't know. Find out the things you can do and tilt towards those. Whatever you think might be effective, give it a shot.
Thanks, that's really helpful. I think we talked about doing some harm reduction services, especially since opioid crisis has hit our county really, really hard. I don't know what the stats are about Everett, but we're on the I-5 corridor and we're basically the end of it. So it all ends up in that area. And then we just elected kind of a fascist sheriff for our county, which is also great. So. Anybody have follow-up questions?
No, I just think that's really encouraging to hear, small numbers that if you're focusing really issue-based and locally, but still related to health justice, that you can kind of punch above your weight, because there really isn't any kind of organizing game in town, and these issues just matter to people, especially when it comes to the opioid crisis here in Snohomish County.
Yes.
I've seen some stuff in New York about doing Narcan distribution, which is the drug that saves you from overdose death. Mm-hmm. So that would be something that'd be really interesting.
Mm-hmm. Yeah. Another thing that I've heard chapters try to do, I don't know if they succeeded, is demand that the police in town hire social workers to go up to respond to mental health and opioid calls, because you don't want to give cops do a bad job at everything, but especially handling mental health and OUD style issues. So demanding that the city hire someone who's trained in this kind of thing to go respond to these calls can be helpful. I don't know. I don't know how it is there, but what I've seen is that maybe in smaller areas, folks who are in power aren't used to getting harassed. And so you've got a little, even a small group can be more effective when the folks you're trying to push aren't used to being pushed.
Mm-hmm.
I can actually speak a little more to that. I'll just come around here so I can be more near the mic. So the city of Everett is where I live, and it's our county seat. And the mayor is talking. There was a recent article in our local newspaper about how violent crime and property crime is down, but because perception of crime is up, the mayor is looking at hiring an additional 24 police officers, which would cost the city $1.8 million. At the same time, they want to take our local city transit system, Everett Transit, and merge it with the county-wide transit system because it costs us like $1.6 million. And they're like, oh, the deficit, it's terrible. So, our city police department does have some social workers, maybe like, I know we got like 2 or something like that, but like, the local sheriff who was elected is pretty fast and has like ordered for the police to stop carrying Narcan on them. So there's definitely kind of some groundwork there, I think, where we could do more organizing around.
Sure, that makes sense. I'm sorry you guys are going through that. That sounds pretty miserable.
Yeah, Washington State isn't as liberal as people think it is.
I'm familiar with like the Hep C epidemic among Medicaid patients, and how the cost of drugs almost compelled Medicaid to not give Hep C drugs to people that need it on Medicaid, just because of the combination of a cost burden and, of course, the fact that drugs can't be negotiated. Really rotten. Actually, my girlfriend worked in that case, the lawsuit, a couple of years ago, which is why I know about it. I don't know. I'm not a politics person. I'm just a policy guy. I'm kind of a little limp flag hanging in the breeze, but the things that I've seen work are things that provide material relief for people around you. I don't necessarily mean like direct aid or whatever. You guys are a small chapter with not a lot of resources. Probably buying Narcan yourself, forming a Narcan like squad, isn't going to be a fantastic use of your time because you only have so many people that can do this stuff. But whatever you can win for people, will bring those people in to fight with you the next time, right? It's a small thing that builds and builds and builds and builds and builds. You know that. But like when Reclaim Idaho, one Medicaid expansion, now there's 50,000 people plus all the rural hospitals and rural doctors that directly benefited who will show up for the next thing. Now they're targeting education reform or education funding in Idaho, and they'll probably win because now they have this mass movement of folks who've been materially helped by things they've done in the past who will come out to play ball next time. In Maine, the Maine People's Alliance fought a minimum wage campaign, I want to say in 2015. It succeeded. And so they turned out everybody who won the minimum wage campaign to get petitions to extend Medicaid in the ballot. They got all their signatures in literally one day in 2016. And then that movement passed again overwhelmingly at the ballot box. They built, one campaign and turned it to another, turned it to another, turned it to another. That thing seems to be working even in pretty conservative states and conservative parts of the U.S.
Thanks, that's really helpful. I think in general, we're trying to find more material ways we can make impact, especially when Rick Larson has so much money and he's never going to support Medicare for all because he's like a corporate bullying lobbyist. And we have somebody running against him, but it's kind of a little bit hard. Kind of going back to like the policy level, does anybody want to follow up? Something I'm still super confused about is pharmacy benefit managers, and I don't think I'll ever understand them because it's like such like an obtuse, complicated middleman thing. I think you had like 2 pages on it. Can you just kind of explain it again so I can get it?
Sure, totally. So I wrote this down so I would get it right because they are complicated. Sometimes I forget. So I wrote down a couple of paragraphs. I'll go through them right now, and you can tell me if it's more helpful. And then I have an example of how it affects Washington, and maybe that'll make it a bit more useful, a bit easier to understand. So top line is that drugs are a complicated business. There's a lot of them, for one, and they work differently. Some are better or more cost-effective than others. Some are way more expensive. Some don't work. Some are old or new. You've got new drugs and old drugs, generics and name brands. Each have very different pricing schemes and therapeutic benefits, right? I think in the book I used the example of Prozac. Prozac costs $500 a month, but the name brand fluoxetine costs $17 a month because it's generic, right? So an insurer, and this would include a single payer, would prefer the one fluoxetine instead of Prozac because they are the same drug, but one of them costs a lot. I can't do math right now. It's too early for me. One of them costs a lot less than the other. So it wants to spend wisely and encourage patients to go on cheaper drugs and avoid paying unnecessary drug costs because they're really high. And so they do this by tiering drugs. There's the drugs you can get more easily on the bottom. The drugs takes a lot of work on top. Some drugs have no copay, some have a small copay, some have a large copay, and some just aren't covered. Some drugs, generally more expensive drugs, or drugs with generic options, have required prior authorization from the insurer. The insurer has to give you the green light before you can pick it up. Others can be up without any hassle. And this big structure, this big pyramid is called a formulary. Now, formularies are fairly regulated. You can't exclude a drug from a formulary if the drug doesn't have a significant, you can exclude a drug from a formulary if the drug does not have a significant or clinically meaningful advantage over other drugs in the formulary, and if there's a written public explanation of why the drug has been included, right? So a formulary could exclude Prozac if fluoxetine is included, as long as they provide their argument, right? If there's a drug in the formulary that has the same perceived therapeutic benefits as a different drug, they can exclude that drug. Now that kind of doesn't always carry through. Just because a drug is named brand or generic doesn't mean it works exactly the same way. Some drugs, you have multiple drugs that aren't versions of each other, and like they test differently. Folks respond differently to different kind of drugs. A good example is like bipolar drugs or antipsychotics. You've got like 12 different antipsychotics, and they all work very differently. And you could argue that one of them is one size fits all, but actually each drug has like a different like flavor, you could say, and some folks respond better to these, not to these, but not better to these, not to these. So formularies try to like include the bare minimum instead of providing all drugs for all people, which is, again, sometimes makes sense, but very often means that folks get excluded from the drugs that they need to have because, in theory, there is a cheaper alternative available, even if that alternative has awful side effects, for example. So this is all a big hassle, and drugs change all the time. New drugs come out, new studies come out. There's actually a big problem with not enough longitudinal studies or comparative studies across drugs. Drug studies themselves are a pretty skewed process. There's a great book on this called Bad Pharma, which if you ever want to have a nice week is a pretty fun read. So insurance companies contract this work out to PBMs, pharmacy benefit manufacturers. PBMs are just middlemen. Like by and large, they are middlemen. That's their entire reason for being. They stand between insurance companies and pharmacies and drug manufacturers. And so they represent a group of insurers, which means they have negotiating power, so they're representing multiple insurance companies, and determine what drugs are or aren't purchased and where they go on the formulary. They basically build the formulary for insurance companies. Because they have leverage, they can compel manufacturers, the guys that make the drugs, to give them favorable deals. If you don't give me a deal on drug X, it won't be covered by Blue Cross, Blue Shield, Aetna, or Optimum, or whatever in Western Washington, for example. Otherwise, their drugs will be adversely tiered, not included, require prior authorization, things like that. So you go to Walgreens to pick up your meds, or whatever you have in Everett, CVS, local pharmacy, cool. You go to the counter, and the person looks up your prescription, and the PBM tells them how much it charges your copay, and that's your transaction. The PBM bills your insurer for the rest, for the cost of the drug, then reimburses Walgreens, usually to buy the drug from the PBM as well. So there are 3 huge PBMs in the US, and they cover like 80% of the population. It's like a super monopolistic industry in the US. And of course, this consolidation does not reduce in lower costs. A lot of these guys cut sweet, like a lot of insurance companies now own PBMs. I think Aetna owns CVS's PBM, which means that it cuts itself sweetheart deals and keeps the change for itself, which is like pretty insane that you can do that. But the PBM makes money in 2 ways. One is through the thing called the spread. They charge the insurer more money than they reimburse the pharmacy. They make it so the insurer has to spend $200 for the drug, but they get it for $100 from the manufacturer, and they keep the $100 for themselves. And then 2 is through gaming a discount and rebate model. PBMs demand low costs from manufacturers, and they get those in 1 of 2 ways. One is direct discounts, and one's rebates from the manufacturer after a drug is purchased. And so discounts make sense. Like list price for a drug is $700. Give it to me for $500 or $400 or $300, $100. Cool. Then the list price goes down to a de facto $100. Rebates are a little bit different and they're a bit more dangerous. A rebate is you sell me a drug for $700, and once I buy it, you give me a $600 rebate. So like the net cost is $100, but the actual sticker price remains $700, right? Now, a lot of like things like Medicare, Medicaid set their drug prices based off the list price, not the net price. So one of the reasons that the Hep C drug was so expensive for Medicaid in Washington was that Medicaid's list price for Hep C drugs was $28,000. Now, the Coast Guard, the Department of State, the military, some insurance companies got really sweet deals, brought that down to like $12,000, $8,000, which of course is still wildly expensive compared to what it costs in India, $234, I think. But these like other insurers, got rebate discounts, and Medicaid didn't, had to pay list price or a function of list price. So even though like the actual cost was lower, the list price was inflated, and so other companies had to pay more money, if that makes sense. Also, your copay is set on the list price of the drug. So if there's a $700 drug that's being sold for a net of $100, your copay is being set on that $700 price. So even if your insurer gets a rebate, you're still paying as if that drug costs $700, which is totally rotten. And you don't get any part of the rebate. The insurer gets the rebate. The PBM takes a slice of the rebate. It may or may not pass it on to the insurer, and the insurer will not pass it on to you. So that's PBMs. They attempt to control costs of drugs in the US and regulate how drugs are used, but they control them in favor of the PBM. They exist because insurers are too small and too clumsy to negotiate drug prices themselves. And so as middlemen, they create new costs from the inefficiency and keep it for themselves by cutting weird deals with drug manufacturers and kind of forcing everybody to play by their rules. They invent new costs and keep that for themselves. Does that make sense?
Yes, it makes a lot of sense. It is a really complicated system, but I think you've analyzed it very clearly. So,
I mean, they're leeches. Mm-hmm. I mean, in a very simple form, right? The service they provide is a service that a single payer can do immediately. Drug negotiations. We already have people who do research on what drugs are effective. They're all in the federal government. Like, we don't need these things. And mostly, like the fact that we see so many vertical integrations of PBMs and insurance companies tells you that like it's very profitable to own both the insurer and the PBM at the same time. You can cut sweetheart deals with yourself and keep that money all in house. It's just, which is insane to me. But it comes at the expense of local pharmacies who are often penalized by not being part of the pharmacy owned by the PBM. They're rotten. They sit in the middle and leech resources from both sides.
That makes sense to you?
That helps a lot.
It's better.
Yeah.
Mm-hmm.
So we already have people in the federal government doing research about what drugs work. Like, so how would we get rid of PBMs under single payer?
I mean, probably buy them out. I think the way we get rid of insurers and PBMs is by buying them out. I think you gotta, as the guy, I forget his name, I should learn his name, the guy who pushed through the Canadian Medicare model said famously, the reason he won doctors over is he filled their mouths with gold. He just gave them a lot of money and they stopped complaining about single payer, and it worked out pretty well. I think we just gotta end up buying out insurance companies, buying out PBMs. It'll cost us $500 billion, $250 billion, but we spend $3.6 trillion in healthcare a year over a 10-year span. That's a pretty reasonable cost. Also, that way we get their infrastructure, we get like a lot of the resources. Like, these companies have built up things that could be useful. I work for an insurance company, which is why I learned a lot of insurance, which is why I went there. And the tools I build in my day job would be useful in a single payer model. I build like tools to figure out, like, someone goes to the hospital, you got to mail their doctor, that kind of thing. That'd be a thing you want under single payer. I think like, if you try to force these things just not to exist through competition, you'll get a lot of pushback from a lot of people. Then you have like, I think that'd be a difficult sell. I think just buying them out outright is how you get past this like awful hump corporate involvement in healthcare.
Alex and Randall, do you have any follow-up pharmacy benefit manager questions?
No, thank you.
No, I don't. Thank you anyway.
Awesome.
Tim,
Go ahead.
Okay, Tim, if I can, I'm in a situation like that. I had low-income subsidy, extra help under Social Security, and I recently lost that because I won a settlement from my union to repay my pension. But so my drugs went from $8 a month. I have COPD, so I was taking 2 inhalers, and it cost me $16 a month. Because I lost that, the retail price of those drugs, and I'm probably beating a dead horse here, but the retail price of those drugs is $235 a piece. Now, my insurance plan will lower that to $50 because my doctor and I both complained. But that's the situation people find themselves in. So what do you do? I mean, can I pay rent or can I afford to buy my drugs? So
yeah, it's horrendous.
Was very informative.
Well, thank you very much. I'm sorry you're going through that. It's really horrendous, right? Like this is clearly the manufacturer is making a profit off that $16 price, but it's jacking it up because they can and no one can stop them. It's absolutely rotten. It's really, really infuriating.
So to shift the conversation a little bit, we were talking about the last book club we met, trying to look at and understand the idea of food deserts and how they contribute to the overall health of a population. You mentioned in your book how single payer is the first step on a ladder to broader health justice. And we've been looking at our county and trying to understand what the overall effect of food deserts are in areas where we do have a lot of rural population here. And the food deserts are places where there's little or no access to adequate food. And the access that people do have is very limited to highly processed, consumer non-nutritional food. Did any of your research or work or any of your travels do you have any reflections on the presence of food deserts in the U.S. and how they affect health outcomes? Have you seen any activity in that area? Do you have any thoughts about that?
Yeah, totally. So food problems happen in one of two ways. I think about this in the book. There's malnutrition and there's poor nutrition. I had it phrased better in the book. I forgot what I said. But either like you're not getting enough food or you're not getting the right kinds of food, right? Either you're going hungry or you're just eating processed food, heavily processed food all the time. Malnutrition leads I think 2 or 3x times in poor health outcomes, self-reported. Malnutrition leads to things like diabetes. Diabetes has comorbidities like cardiac failure and amputations. Southwest San Antonio, inside the Loop, is a massive food desert. It's a really poor, these food deserts tend to be concentrated in poor or rural areas, like most problems are. This is just another way we kind of push folks into being miserable if they're poor or in the wrong place. In southwestern San Antonio, you've got the highest rate of diabetes-related amputations. It's a giant food desert. It's near a military base. If you're not in the base, you're out in the middle of the city and there's no grocery stores nearby. It has the highest rate of diabetes-related amputations, I think, anywhere in the U.S. Certainly in Texas, but I think it's the national leader in diabetes amputations. That's all because of nutrition. Nutrition leads to It leads to things. It leads to diabetes is the big one. Diabetes and obesity are the two biggest chronic conditions in the U.S. and or that run risks of having comorbidities that are really dangerous. And those come. A thing that I've seen in response to it, there's one experiment happening in Florida right now. Forget where in Florida, but it's a pretty conservative town in Florida, opened a city-owned grocery store, a public grocery store. The city took, like, there was their last grocery store was closing. I think it was in Baldwin, Florida. Their grocery store was closing, so the city put together money and opened up a grocery store that stays open and gives people food. It still sells it. It's not like a food pantry, but because it's city-owned, it's got some resources to stay open, provides good jobs, and kept food in the community. And so far, it's been succeeding. It's making a profit, which is great. It's staying open. People are getting the food that they need. It can stock healthy food that's like responds to local demands and local needs. I think that model is going to proliferate. There is an attempt in Philadelphia to solve urban food deserts by giving private companies money to expand and open grocery stores, but that failed entirely. It's not profitable still to sell poor people vegetables at private rates. And so those grocery stores opened and then folded within a couple of years, or it's like pivoted into being like specialty grocery stores, which would serve gentrification, not like actual community needs. I think the way forward is publicly owned groceries. It's not unreasonable. I think we see this model in Baldwin, Florida, which is heartening going forward. And I think it does a lot of good things. It doesn't cost that much overall. I mean, Baldwin's not a rich town. They're able to afford it with a small tax increase. And it keeps people like healthy going forward. Now, I don't know how big their rural spread is compared to where y'all are at. Maybe these are different scenarios, but like private industry, private food stores aren't going to solve this problem. These things aren't profitable to solve by nature. And so I think it's got to be a public operation to get people the food that they need.
I saw a wildly successful experiment I think it was in Chicago, where an African-American man organized first a community garden, and then he further expanded it into organizing basically a food cooperative where local people would come in and both work in the garden and then become members. And then they would be growing fresh organic produce and then selling that not only to their members, but to the general public at greatly reduced prices. And people were, the project was obviously flourishing, and it really addressed the issue not only of the food desert and nutrition, but also helped in its own small way to alleviate poverty in the area. Because people were getting much more for their food dollar, and they were eating much healthier food, and that translated into money saved that they could then apply to the maintenance and care of their families.
That's great. That's really cool.
Yeah. Any questions?
I think I'm really curious how that fits at like a local level, and then how that fits at like a national or state level. Like, in general, like trying to combat and like improve social and structural determinants of health, like massive structural determinants of health, like mass incarceration is like something that's like at a national level, but then like something like groceries, like, is that something that just communities are naturally going to come up with, or is that something that needs to be like federally funded?
I think all these things require federal funding. I tend to be kind of a one-track pony when it comes to where money comes from. I think it all comes from the federal government, or ought to. I think this is going to be the kind of thing that how it plays out is now we're just purely hypothesizing, right? So I could be totally wrong. Maybe it'll end up being at community levels. But I think you need seed money from the federal government to open things like community-owned grocery stores, public grocery stores, because the problem is that the money isn't there in the first place. If we're willing to spend money on financing, like the Philadelphia experiment was a federal project, at least in part. Like the Medicaid structure of partial federal and state funding, like, does make sense for local projects. I think the money should all come from the federal government, but like that kind of co-op model is one that exists. I don't know. I think like it's in the interests of the federal government to spend this money to get people food. I think more likely it'll end up being a joint project if and when these things happen than a purely federal one. But I think it's federal direction. I think it's a federal initiative. Or like even these Sanders and the Jayapal bills include like local like hubs for the single payer program in like regional levels, which I presume means the state, but they're not. It's not like defined yet because they don't need to define it yet. And I think these serve as like the locuses of experimentation going forward. I think these regional or state or whatever hubs can request, like kind of what Medicaid does right now, request a grant from the federal government to try a new thing, see if we can deliver care more efficiently without cutting anyone's access. And I think that's how we'll see like I think that's where money for projects like food or shelter or other kinds of quote unquote experiments to increase health outcomes and cut costs will come from. Kind of that's like locally directed, locally managed, federally funded programs.
That's really interesting. Any other follow-ups about food and housing and other social?
Well, I had a kind of an experience with this when I lived in North Carolina, because I was a trained vegan culinary chef, and I was talking with a lady who ran an empowerment center for local women. And she invited me to come in and talk to everybody about food and nutrition. And we were just, she said, now what would you talk with people about? What kind of a class can you give? And I decided to start with the basics, and instead of giving them a lot of stuff about nutrition, talked instead about how to make a good green smoothie. And so she said, well, how do you make a good green smoothie? And I started explaining. And we were talking about ingredients. And she said, now, wait a minute, if you are pushing only organic ingredients, none of our people can afford that. And I said, well, the answer to that would be to starting a cooperative to get a bunch of people together and buy organic food. And when you do it that way, sometimes you can even do that under a business license legally, and you can get a great discount, and then you can just share that way. And I foresee that the answer to, the partial answer to this would be in keeping with what you just mentioned about the federal support, but also having that met with local involvement and organizing around something that is just very simple and very tangible. You know, how to get vegetables to put into a blender and how to pay for those vegetables. So it's encouraging to be able to see those potential steps laid out that as something that really any well-organizing group can do around this issue. And that would, you know, helps to address health, food, and nutrition. So.
Yeah, in theory, you know, single payer gives you levers of local control. It has these local hubs that, of course, are in the Jayapal and Sanders bills. And so if you build the organizing power to demand that someone use these levers to seek that federal funding, it really opens up the scope of projects you can take on at a local or community level.
Following up with how the federal government can kind of counteract these like capitalist leeching off of people's health. Back to like the opioid crisis. So I mean, capitalism has already like killed people with the opioid crisis, and it's like a lot of it is like irreparable damage, where people are addicted, or you know, like how does like single payer use those levers to actually counteract the harms of the opioid crisis and start like tapering people off of it and providing like pretty intense detox centers? Like it's a massive project. Like what would that look like?
Sure. So there are things single payer can't do, and there are things beyond single payer, right? Like single payer isn't going to solve the opioid epidemic. This is like a much bigger structural thing than like an insurer could take on itself. What single payer can do is cover medication assisted treatment, which is like essential. Like that's pretty canonical. There's no wiggle room there. Like people can't quit cold turkey. They need meds. They need bupe, etc. It's early for me. Single payer can cover these. Single payer can cover the drugs. Single payer can fund inpatient rehab. Single payer can fund it with more than like the 3 days or week that you get through a private insurance company. Which in theory would generate more rehab centers opening because now there's guaranteed funding for rehabilitation. One of the problems with OUD is that generally, if not universally, but not very profitable, treat patients who have OUD. Insurance that'll fund like the full core cut off after a week, even or 2 weeks, whatever, before you're better. If single payer covers suddenly there's more money in business, so to speak, taking care of people. And like I don't think that's good necessarily. I don't think it's good to like play the economic game, but it's a reality, and I think that's interesting. Suddenly there's more incentive to do the full course of care because now there's more guaranteed income available for doing it. Now that doesn't solve OUD. That's like that's an attempt to handle the things that we got now and solve the cause of the problem. We understand things like deindustrialization and lack of income, lack of jobs, and like lack of safety at home are things.
We lost you. We lost him.
Oh, looks like he might be back.
Is he back?
He's back.
You're back.
Sorry about that.
No problem.
Sorry, my computer must be silly. Can you hear me?
Yep.
Yeah, we can hear you now.
Okay, cool. Sorry, I was saying like we understand the causes of OUD or the things that drive it. It's deindustrialization, it's lack of income, it's lack of safety. Single payer doesn't solve those. If you wanted to like really address OUD, you would go into communities where these things have happened and create jobs, meaningful labor, give people money, give people like to lead a life with that they get rid of the things that tend to correlate with the use of opioids, which is not having a job, that's not an income, not being able to like support yourself. Oop. My internet connection is unstable. Why is that?
Yeah, it says your network bandwidth is low.
Anyway, single payer can't solve that. Pardon?
Oh, no worries. You're
Sorry?
helping. You're good now.
Okay. Cool. Single payer can't solve this. All single payer can do is provide the incentive to tackle in the way that we can, right? If single payer is funding the full rehabilitation, the federal government is incentivized to take on projects that OUD or drive it down. But single payer isn't going to solve it by itself.
Yeah, I guess that's the idea of health justice is like way bigger than that. Yeah.
May I ask a question?
Yeah, please do.
Okay, this is Randall. Tim, I'd like to know, I used to work with Medicare for 6 years as a counselor in Southern Nevada. And let's go Bernie in the Caucasus today. But my question is, the questions I receive from people I talk to, both at work and in my neighborhood, are what will single payer do to the VA, TRICARE West, Champus? What will it do to improve Medicare? Can you help answer those questions? I mean, there are about 5 different silos we have here that deliver health care, publicly funded for the most part. And how will single payer alter those?
Sure. So the VA facilities stay in place. So if you go to the VA, you can still get it. There's a big problem with VA funding. The VA is underfunded. Single payer, in theory, can address that, but I mean that requires. I think single payer funds the insurance part, but not the provision part. You still got to tackle the problems of why the VA is underfunded. I believe with TRICARE, I think TRICARE still exists under single payer, but there's no cost sharing. You just have access to the VA facilities. I think that's the way it works. But like you don't have premiums, deductibles, or copays. You still have full funding, or still all your care is taken care of, so you can go to the facilities you want to. Medicare is totally revitalized under single payer. Medicare for All is the popular name, but it's not traditional Medicare. Medicare was built over a long period of time. It's got weird carve outs. It's like a honeycomb, kind of add on sections over time instead of forming a cohesive whole. Medicare has cost sharing. Medicare has spending limits. Medicare has no out-of-pocket limits. Medicare has like a pretty half-assed drug plan. Medicare is privatization for Medicare Advantage. This is a total revamping. This is all care for all people, all funded through the federal government. So like most of the problems people have with Medicare around things like long-term care or cost sharing in Medicare Part B or Medigap insurance or lack of eligibility for Medigap insurance go away. These problems stop existing once you have single payer. It's an expanded and improved Medicare for all, not Medicare traditionally as we have it. Medicaid similarly becomes to some extent obsolete under single payer. You don't need the state to pitch in if it's all federally funded. Whether or not that structure continues to exist, I don't know. I think it should. I think you still want to keep that state oversight of state programs intact, as long as they're being forced to adhere to a set of strict regulations about what is covered, which like is entirely doable. But the things people have problems with now in Medicare, and to an extent TRICARE and the VA, are addressed through the single payer program.
Thank you.
Thank you. I saw a dog. How's that dog doing?
I've starved, unhappy, miserable mongrel who gets more attention than many children do. And London is fine and would sit on the couch and greet you, except London is looking for someone to give her a muffin. Oh! Who's that?
This is Ume.
Ume. So Little Plum, huh?
Mm-hmm. Yep.
She's a beauty.
He's a real nice boy. He's a teddy bear basically. All I wants to do is hang out and sleep. But so do I, so it's a pretty good fit. Thanks, Plot.
London's to all of our protests, and sometimes she comes to book club, so she's definitely our mascot.
Right.
Michelle had a question.
Yeah, so my question is, I might be shifting gears a little bit. I stepped away for a moment there. But I was wondering how single payer will affect reimbursement for providers. And the reason I'm wondering is I have a really good friend. I've known her since preschool, and she spent a lot of her life in Southwest Washington, in one of the highest poverty rate towns. Her mom has worked, her dad died when she was 13. Her mom has worked as a waitress since she was 14 years old. And against all odds, she has gotten into the UW Dental School, which is the third best dental school in the country. And but she's gonna have to take out $500,000 in student loans to fund her education. And she has a lot of concerns about single payer and Medicare for all, from how it will affect her and her reimbursement when she gets out of dental school someday. She says, that sounds nice and all, but I'm taking out $500,000 in student loans. I know that with Apple Health in Washington, reimbursement rates for cleanings for these different things are really low. So I was just wondering how single payer might affect reimbursement rates for healthcare providers. Of course, when I talk to her, I say, Shauna, when you get President Bernie Sanders in the office, we're going to forgive your student loan debt. But, you know, I was just wondering how it affects medical providers.
So there's two prongs here. One, you already touched on, like a single payer program requires, I think, that medical training is free or reimbursed, right? Like for a couple of reasons, right? Like right now, what is it? 50%, sorry, 80% of, is it 80%? It's some huge number of people in medical school come from the top income quintile in the US. They're overwhelmingly white. Like you have a wildly unrepresentative medical body compared to this, the patient body that leads to a lot of problems. If your doctor doesn't look like or come from where you come from, there's a higher rate of like incidents of malpractice, not like it like intentionally, but like cognitive biases and blocks in the path to give people care that they need. So a big component of health equity is making medical training free, not just for doctors, but for nurses and PAs and home health aides as well. Otherwise, you're right. You come in with $300,000, $400,000 in student debt, and you're looking at a pretty big mountain of debt, which drives folks to take on specialty roles instead of like primary care roles, which is like not great for American health either. We have a primary care provider shortage for this and other reasons in the US, which is a shortage that we created in the early 90s. We thought we'd have too many doctors. There was a New Yorker cartoon. I think I put this in the book. There's a New Yorker cartoon of doctors in a bread line. So the Clinton era policy was to restrict admission for primary care providers, restrict residencies. We kind of created this problem ourselves. But sorry, yeah, forgiving student debt and making medical training tuition free is a big part of this. The other part is that right now, if you're a current provider, half your time you spend dealing with billing and billing infrastructure. You got to hire folks to handle billing and claims reimbursement. You got to hire someone to deal with like the 14 different kinds of insurance you work with, and like the 10 plans per insurance kind that you have to navigate. And that's time you can't spend seeing patients, right? Doctors spend literally half their time dealing with billing processes or hassling insurance companies. That's time they can't spend getting paid to see patients. What single payer does is remove that time and cut it down from 50% to like 2%, 10%, whatever. So they can see a lot more patients in the same amount of time, which leads to higher overall reimbursement. Reimbursement under single payer would be higher than current Medicare reimbursement, lower than private insurance reimbursements, but like we're not talking about like I forgot what the estimate is for how much higher than current Medicare, but like it's a bit higher than what Medicare pays right now. But what you lose in unit volume, you make up in what you lose in unit costs, you make up in like volume.
Thank you. That's just super helpful for just talking with my friend there, who I think under most circumstances would be super on board with Medicare for all, but like not unreasonably like, you know, signing on to like a $500,000 student loans, has actually looked into like joining the Air Force after school to like pay off those student loans. I understand why she's had those hesitations, and it was a much more personal question than a chapter question, but it's gonna make chatting with her about that a whole lot easier. So thank you.
Absolutely, absolutely.
Is there?
Yeah, we'll just have one more question, and then yeah.
Want me to ask about that?
Yeah.
I don't know if you're familiar with this term in the book. Obviously, you've done a tremendous amount of traveling. You've talked to a lot of people, and you express very eloquently in many places in the book the kind of pain that you both have experienced and been witness to. There are a number of writers nowadays. One of the ones that I'm familiar with, his name is Chris Hedges, and he talks about that one of the psychological effects of capitalism is anomie, which was a term that was coined by Emile Durkheim in the late 1800s. He was a French sociologist, and he wrote a treatise on suicide. And anomie is the condition that people fall into when their ethical and social structures break down and the relationships break down as a result of the conditions that society puts them in. And to translate that into modern parlance, when you look around and you see all the injustices that are caused by the current capitalist system. And anomie was basically characterized by worthlessness, frustration, lack of purpose, and despair, which can translate into people becoming so immiserated and so discouraged that they no longer will get out and demand their rights for health, justice, and single payer as a human right. So I'm wondering, on the one hand, if you have any thoughts about this idea of anomie in the conditions that you have encountered in your own work, and also to, in looking forward, if you have any thoughts or perceptions about the possibility or likelihood of single payer succeeding as early as the next election. In whatever way you want to address that or think about it.
Sure. So I'll take that in opposite order. As far as like when single payer could happen, frankly, I don't know. I don't want to pretend that I understand how politics works or that I can predict what will happen in 2020 or 2022. Like, I don't know. My best guess is that the only way forward is Sanders has got to win. I'm all in for Sanders. I'm usually loath to hop aboard a cult of personality for a politician, but for Bernie, no problem, because he is the only single payer candidate out there. Whether or not he can compel single payer to happen in his first 2 years, first 4 years, frankly, I don't know. We know that, like, we know historically that single payer hasn't happened because of good presidents or good senators or good policy people. They can be bested, and they are bested by a reactionary establishment that can outgun, outmaneuver, and outspend them. It requires like a massive popular movement that can hold democracy accountable to seize this thing. I think Sanders gets that. I think his organizing style in the campaign is one which could realize or set the seeds for a grassroots campaign to kind of build that structure. Whether or not it works, I don't know. I hope so, but I really don't know. I'm not saying that pessimistically. I'm just saying I just literally don't want to guess. It's not responsible to do. I hope so. I mean, I think it's like Adam Gaffney, president of PNHP, put together the idea that if single payer is a 3-act volume, we finished Act 1. We have the bills. But Act 2 and Act 3 are, that's in any kind of 3-act play. That's where the conflict is. And I think we are stepping our toes into that pool right now. I think tying that into your first question, the way we win this is by giving people even like a little bit of hope. And I think you do that by giving them any kind of little material thing. I think the point of Bernie really stretching executive orders to their limit is to show people that things are possible, that we can have nice things, that these things are doable. And from that, give people a thing they can hold on to and use that to demand the next big thing. It's the if you give a mouse a cookie style of organizing. I think that's really important, right? Because anomie does make sense in the U.S. We've been pretty thoroughly atomized. We've been pretty thoroughly like stripped of the things that give us dignity and justice and peace, and that sucks. And people have been utterly dehumanized. And so I think whatever can be done to give folks a little bit of something that validates them, that shows them that they have worth, lets them lead an easier life and be happier with their family or with themselves, is kind of like the little seed that will. I'm using too many plant metaphors, but is the seed that could sprout into something bigger and something better. I don't think you can ask people to like hit the barricades right now for a thing that might not come to pass. But I think if we can win small victories and turn into larger ones, that's how you awaken a broader class consciousness.
Well, looks like our time is up. Thank thank you so much for this. This was really
No, thank
cool.
y'all.
And thanks for tailoring everything to our questions. It's really helpful and specific to our topics. I was gonna break these up into little videos for YouTube. Is that okay?
Sure, go wild.
Okay, great. All right.
Cool.
Thank you so much.
Thank y'all very much. Have a nice day.
Thank you for all your work and your great book. We
Oh, thank
really
you.
enjoyed it. Yeah, it was
I really
tremendous.
appreciate that.
Yeah, thank you. And good luck
Thank
to you, whatever you're doing.
Thank you. Y'all as well. Well,
Thank
have a
you.
nice day.
You too.
You too.
Take
Thank
care.
you.
Bye-bye.